So good afternoon, welcome everyone. So this is our 37th meeting of the Blood Transfusion Education and Discussion Group. Most of you will know me by now. My name is Selma. I'm one of the chairs. Today we'll be looking into what happens when antibody meets antigen in vivo, an introduction to intra and extravascular hemolysis. We have a very special guest with us today, and most of you will know her. She's a BMS with over 28 years of experience in transfusion science practice. She also teaches healthcare professionals, and she's probably best known for writing the current edition of BBTS book, An Introduction to Transfusion Science Practice. She is currently doing a project which is running a CPD website aimed at professionals specializing in transfusion science. And it's Robina. So just before I invite her in, I'll be taking you quickly through some housekeeping. So we've put everybody on mute at the moment, just to kind of prevent any background noise. If you do wish to speak, either pop your question in the chat or raise your hand and we'll let you in if you would like to speak, or we will be just reading out your questions. We might not be able to get through all the questions depending how many we get. We're happy for you to either email us your question or email the speaker directly, and we'll try to do our best to answer your questions. Also, this session will be recorded, as all of them are, and that will be uploaded onto our YouTube channel. And by staying on this call, you agree for this to be recorded. We always do our best to anonymize all the names and also questions, but sometimes that's not possible. And we also kindly ask you to complete the evaluation form at the end of this. So Sasha will put it in the chat box towards the end of this session. Please complete it, because your feedback is very important to us. It helps us plan future events. So yeah, I think let's get started. Robina, over to you, and welcome.
Thank you very much. That was very nice of you, Selma. So it's lovely to be here. So just to reiterate, I do love to teach transfusion, and if you want to get in touch with me, you can email me at that email address. You can find me on LinkedIn, and I am on Twitter, X, whatever it's called. I don't do a lot on there, but if you're on there, you can find me on there as well. So this is the title of the talk when I was asked to do this, and already I have changed it to what may happen when antibody meets antigen in vivo. Okay, so I'm going to take you through an introduction to intra and extravascular hemolysis, and the point I want to make here is there won't be answers to everything in this. We haven't got very long, but what I would like to say is to treat this as a jumping off point for yourself. So when you find something you think, oh, that's really interesting, think of that as the starting point for you to carry on and find out where you want to go with that next. So I hope that's okay for you all. So let's get started. So look at the basics first. And just to say, I've got a few questions for you as we go, which hopefully you'll get into the chat and give me the answers. And you can ask questions as we go, and you can ask them at the end. That's quite happy to do that. So we're going to kick off first with antibody binds to antigen in vivo. So there we go. That's simple as that. Antibody binds to the antigen. And two things can happen. Okay, so the first is attraction of phagocytic cells, so typically monocytes and macrophages, and this will result in membrane damage, leading to spherocytosis, and we can get premature red cell recycling. The second one is complement activation. Okay, so this is where that antibody binding triggers the complement cascade, and we're talking about the classical one in this talk. And this can lead to macrophage attraction as well, but more concerningly, of more concern, I should say, is the possibility of intravascular hemolysis if the cascade goes all the way to the membrane attack stage. Okay, so that's the basics. So here's a question for you. How many red cells do you think there are in a single donation unit? Just have a quick approximate what you think. Oh, perfect answer. Okay, somebody's gone with 2 trillion. Maybe you've heard that before. Okay, so when we transfuse somebody, we're exposing them to huge amounts of antigen. And sorry, just let me do that. Okay, so we've got huge amounts of antigen going on there. Of course, the severity of the situation will depend on whether the patient has an antibody to those antigens, what type of antibody it is, how much we've given, how clinically significant that antibody may be. Okay. So another question for you. IgG antibodies, we'll start with those. Do they activate complement? Any thoughts on that? We've got 1 no. Anybody else? Don't be shy. Getting a few no's there. Oh, we've got a yes, but they have to bind very closely. Yeah. Yeah, need to be close together. Okay. Yeah, some good answers there. Depends on the subclass. Okay, so we've got some people who know about subclasses there as well. Excellent. All right, so next question. What is the optimal reaction temperature? So IgG, how do they like to react? Okay, yeah, we've got 37, lots of 37s coming in. Yeah, wouldn't expect you to say anything else really. Excellent work. And few of you have done that. Is subclass important? So IgG has 4 subclasses, 1, 2, 3, and 4, handily named. Yeah, so subclass we're saying is important as well. Yeah, excellent. Okay. So, like you've said, so they may or may not activate complement. And if they do, it's likely to stop at or before the C3 stage, which is the amplification stage. And we're going to look at that later on. So as some of you said, they have to be very close together. So we need 2 molecules of IgG attached to antigen sites that are very close together in order to activate complement in the first place. So this can be very, very difficult if antigens are spread far across the membrane. So to give you an example of what this might look like, how many A antigens do we have on a red cell? Roughly. Anyone know that one? Anyone got any ideas?
Robina, sorry, somebody has their hand up.
Oh, sorry, I didn't see that.
That's okay. Sharon, did you? Let me just unmute you.
I've got 1,032,032. That's quite a range there. I like that. So it is 1 million, but 32, I like it. So Sharon.
Sorry,
Sharon have a question?
Sharon, did you want to type your question and I read it out? I'm not sure if I can unmute you.
Not sure. Okay, so I'll carry on while Sharon writes her question. So yes, we've got about 1 million A antigens per red cell. Okay, so if we compare that to something like big K antigen, there's just 6,000 of those on the same red cell if they were K positive. So I'm going to break that down a little bit for you to make it more realistic. So we have 166 A antigens on this red cell here. So relatively, that would mean you would have just 1 K antigen for every 166. Okay, so you can see they're going to be quite spread out. So what this means is when we get that anti-K antibody attaching, what can't happen is our C1 won't bind to it. It likes to have 2, not 1. So it'll just ignore that completely. So that's why some of our IgG antibodies are not going to activate complement. Okay, so hopefully that makes sense to everyone. now. So I think you just got a preview. Okay, so optimal at 37. Clinical significance is variable, and that depends on a range of things. So subclasses 1, activity at 37 is another one. So we've got things like, we know anti-D and anti-JKA will cause transfusion reactions if we get that wrong. Whereas if we've got something like an anti-N or an anti-P1, we know that that isn't going to cause a reaction. And then we've got rarer antibodies that we come across very occasionally that we just don't have enough data to tell us what they might do. So we're a bit more cautious around those. Okay, so this table A3 in your BCSH guidelines, hope you've all got a copy. Sorry, that's a bit blurry. That is the table that will tell you what to do when you find an antibody. So that's in the current version. I know they're being updated as we speak, and they will be a new set out soon. So I don't know what that table will be called then, but for now it's table A3, and it's brilliant to have in your pocket. Okay, so what bound IgG does is it attracts phagocytic cells. It opsonizes the red cell to become very attractive to macrophages. They'll come along and they'll taste it and they think, yummy, I need to do something about this. And then we've talked about IgG and IgG1. So they're actually the ones that do the most damage. So they're very, very attractive to macrophages, whereas 2 and 4 are not so attractive, if at all, to macrophage activity. Okay. Right, moving on to IgM. Do they activate complement? What do we think? Yeah, we're getting lots of yeses here. Yeah, excellent knowledge. Okay. And what about their optimal reaction temperature? And give me a range if you like. Got room. Yeah, room temp 1824, 1822, 5, ambient. Yeah, lots of temperatures going on there. Okay. And are they likely to be significant? Nope. Nope and yes. Some. Yeah, I like that. Hedge your bets. Why not? That's what we do in transfusion a lot, isn't it? Okay, yeah, someone said the magic words, ABO. Okay, so let's take a look. Okay, so because it only takes a single IgM antibody binding to kickstart the complement cascade, we can get completion of the cascade, opsonization of red cells when C3b binds as well. But really, we're more concerned about going all the way to membrane attack. They prefer 0 to 22, and then, as some of you have pointed out, if they've got a high thermal amplitude, they can react at 37 as well, and then we do start to worry about those a little bit. But the big one for us is IgM, ABO antibodies are active at 37. They will activate complement, and they cause us a lot of trouble, which is why we give ABO-compatible blood transfusions, right? Hopefully you all agree with that one. Now, just to point out at this stage is that phagocytic cells are not attracted to the Fc of bound IgM. So the only way IgM binding can opsonize a red cell is through C3b ending up on the membrane because of the complement cascade, which we will look at in a bit. Okay, excellent knowledge there. So we're going to look at now destruction without complement. So here we have some IgG binding, but they're not close enough to attract C1 to start the cascade. So what happens instead is we get macrophages highly attracted to the Fc portion. So these red cells are now bound, that are bound with antibody are now at risk for macrophage action. So this damage results in spherocytosis of the remaining red cell. There we go. And we get that macrophage taking out a chunk of the membrane, and it's taking the antibody with it. Okay, so we get lots of opsonization of transfused donor cells. The patient can become quickly jaundiced, more anemic than they were prior to transfusion, which is the opposite of what we wanted to do, isn't it? Okay. So although we haven't got complement involved, it is still very dangerous when we get this wrong, okay? So Rh antibodies, for example, are famous for not activating complement, but for doing incredible damage. So we know anti-D is a terrifically dangerous antibody. If we were to give somebody with anti-D positive red cells, they will probably have a transfusion reaction. So why do they do that? One of the reasons, this is quite clever. So if we tend to think about our IgG antibodies as stick figures, because it's just easier to draw them that way, but found this lovely 3D picture of an IgG here. So what actually happens is that this FC portion, the lower it is in fucose residues, the higher it is attractive to macrophages and then binding. And this is something that they actually use when they're making monoclonal antibodies. So for treatment in patients, they make sure that they are afucosylated so that they are more attractive to macrophage attention. So it's quite interesting, I think. So it is known that Rh antibodies have very low fucosylation of their FC portion. Okay, so they are yummier. Okay, complement, everybody's favorite, correct? Answers in the chat. We have such problems with complement cascade, and I think it's because sometimes when we're taught it originally, we're not taught about it with respect to red cells and what it does to red cells. So hopefully I'm going to help you feel better about complement by the end of this. So we've got two possible triggers. Like we said, we've got two IgG bound, very close together. C1 will attach to that and start things off. The second one is where we have IgG, and that just needs one binding, and C1 will attach to that. So what happens next? That's what we're going to look at. So here we've got two. I'm going to do it with the IgG, two bound close together, and C1 becomes activated, and this forms a complex of antibody antigen and C1QRS. So here's the question. What does this act on next? Is it C2, C4, or C3? So I'm testing your knowledge of the order of the cascade. Yeah, we've got a C4 in the chat there. Got a C3, a C4. Most people are going for C4. Yeah. Yeah, I've got a few C3s. Yeah, okay. So congratulations to those who said C4. Okay, so it is C4, closely followed by C2. Okay, and what that does is, let me get my clicker right, that will split C4 into C4b and C4a, and then C2 into C2b and C2a. So a little cheat for you. If you see something in the cascade that says got an A on it, it moves away from the situation, off into circulation. If you see a B, it means it's bound to either the membrane or bound to another complement component. So that hopefully helps you remember that a little bit easier. If you do see any textbooks that still use A in the binding, then they are out of date and they shouldn't be doing that. Okay, that should have been fixed in '83, which is when I was still in school, never mind most of you on this chat. Okay, so what happens next is we've got C4a and C2a move off into circulation. Okay, and then we get C4b and C2b binding. This then acts on C3, and it cleaves C3 into C3b and C3a. That C3b, so there are two events that occur here, and I'm going to first follow the cascade all the way to completion. So at this point, all the way to completion, that C3b is going to bind to the C4b2b complex. Okay. C5, C3a off into circulation. So this complex is now called C4b2b3b, shorthand C5 convertase. You may have heard it called that as well. And what this will do is cleave 5 C5 into C5b and C5a. Okay, so you'll notice now the cascade is now, the numbers are now in the right order. So it's only 4 that you need to think of as being out of order there. So our C5a moves off into circulation, and now we've got, oh, I've got something missing there. Yeah, that's not quite worked as it should, but don't worry. So we've got C5b, will then bind C6, then C7, then C8, which in turn binds causes multiple molecules of C9 to bind together. And what that does is forms a hole in the membrane. So it's like a little pore, little punch hole into that membrane. And that allows uncontrolled influx of sodium ions and water into the red cell, which causes it to swell. And once that happens, so at this point, we're getting multiple holes all over the red cell membrane and lots of C5a being produced. So that's an anaphylotoxin and it's very dangerous to us. So once that happens, we've got lots of sodium and water going into that cell and it will burst. And there you've got your free hemoglobin popping out, and that's now escaped around the body. Okay, so that's all the way to membrane attack. Now I want to take you back to the C3 step. So this is the point of amplification. Okay, so what at this stage this C4b2b is actually doing is acting on multiple molecules of C3, and it causes lots of C3b and C3a to be produced at the same time. Okay. So what we've got going on here is that C3b likes to sit on the red cell membrane, and it is very, very attractive to macrophages. So that's our amplification step. Okay, sorry, can you all hear me okay? I just got an internet interruption, but I'm hoping you still got me. Yeah. Yeah, excellent. Okay. Fab. So we've got C3b coating the membrane. So this is the amplification step. So it's quite good because it is self-limiting. So we don't have huge amounts of C3, so we will use it up fairly quickly. So that can halt the cascade here. The other thing that also happens is that C3b has got a very, very short half-life. So it quickly degrades to C3d, which macrophages are not interested in at all. They don't have a receptor for it. So this red cell will now survive normally, which is great news because it'll just carry on through circulation. It will act as a normal red cell. So we pick that up in the lab when we do our DAT. We will find that, and that gives us information that's really useful because it says this patient in the circulation complement has been activated at some stage, and that might lead us into a different investigation depending on what else we know about that patient. So that's good information for us to have. Okay, so hopefully you are all okay with that whistle-stop tour of the complement cascade. Yeah? Okay. So now I'm going to talk about intravascular versus extravascular. So why do we get one in one area and one in the other? All right, so my patient confirmed group O, but let's have a look and see what happens if we make a mistake. I'm going to give them some group A cells and see what happens. Okay. So because my patient is group O, they already have pre-formed ABO antibodies ready and waiting in large amounts in their plasma. So we're going to get IgM and IgG. So we've got both types. So concentrating on the anti-A in this picture because I've given A cells to this person. Okay, so as those donor cells enter the circulation, they're immediately going to have that antibody attaching, and we're going to get almost immediate activation of the complement cascade. This is going to cause problems. So if the cascade becomes uninhibited, then we're going to get lots and lots of holes in the red cells. We're going to get lots of anaphylotoxins released. So the C3a and the C5a are going to be released into circulation. And to think about this even more, look how fast a red cell is going to travel around your body. So it's happening everywhere as well. Yeah. So it's a pretty serious situation we've just put ourselves in. Yeah, completely scary. So this is our trigger. Typically, incompatible ABO red cells versus ABO antibodies. IgM and IgG are active at 37. So the IgG is going to cause the opsonization for phagocytosis as well as the C3b bit. So we will get a bit of extravascular happening at the same time as the intravascular. So the patient can have really quickly, within 5 to 10 minutes, have signs and symptoms of red cell destruction. So things like cytokine production, anaphylotoxin release, red cell lysis in the vascular system, leading to free hemoglobin, all happening within 24 hours after transfusion. So that's our intravascular setup. But when we take a look at extravascular, so in this scenario, I'm quite happy. My patient's O positive. The antibody screen was negative. So I've selected some electronic issue O positive to give. But let's have a look and see what happens when we get into the circulation. So this patient has an antibody that I've not detected, I've not found for some reason. Don't know what the reason is yet. But as the antigen positive donor cells enter the circulation, they quite quickly become coated with the patient's antibody. But the question is, why are these removed extravascularly rather than intravascularly? Okay, so I'm going to hopefully take you through that so that you've got a good understanding of why that is. Now, we do have monocytes in our vascular network. So phagocytic cells in the vascular network are going to be monocytes. When they migrate into the tissues, they change to macrophages. Okay, so that's why I'm talking about monocytes now, because we're still in the vascular network. So in theory, these are capable of removing the IgG-coated cells. But what we have got is bucket loads of free IgG floating around in our plasma. Yeah. What that means is that because our monocytes are they just go around tasting everything, that they are completely full, usually, of free IgG. So they're tasting all the IgG you've got floating around in your plasma, so they're just full. Yeah. So any monocytes floating around in your vascular system are already full. Their Fc receptors are full. So if you've got donor cells in your vascular system, they're not really going to be noticed. Now, when you get to the spleen, okay, spleen is the largest organ in our lymphatic system. It recycles our damaged red cells for us. And for that reason, it's packed full of macrophages. So my diagram is very sparse, but that's so we can see things clearly. It's actually crammed full of this, and it's pulpy, full of red cells. It holds around 20 to 30%, I think, of our red cells when we're just at rest. So as the circulation reaches the spleen, if you think of it as if you were driving along a free-flowing motorway, I know that isn't very often, but occasionally you get a good drive, don't you? And you're going at 70. And then you come off and you're thinking, right, going into the city centre, and we hit traffic jam. Okay, so first off, we've got hemoconcentration going on. We've got huge numbers of red cells just bumping up against each other. And we've got this phenomenon called plasma skimming. So this is where the free IgG that we saw in the vascular network starts to be pushed out. So because of the right angles and because of the concentration of the red cells, that free IgG doesn't enter the spleen, which is brilliant, because it means these macrophages have all their Fc receptors completely free, or pretty much free. So they are absolutely free to get on and start tasting donor cells and think, yeah, that's one I want to eat. Okay. So if we have normal, undamaged, unbound red cells entering the spleen, and this is my amazing animation, just look at that. It's perfect, right? Yeah, so they will be able to pass through. Macrophages aren't interested in them. Might give them a lick on the way past and think, oh yeah, but no, I'm not interested in that. Go through, and they will exit, being able to completely deform, slip through the capillary network and exit that. Okay. Now, when antibody-coated red cells, in this case our transfused donor cells, enter the spleen, the macrophages quickly get to work and they bind to that FC portion of the bound IgG. So we get chunks of the red cell membrane nibbled off. The red cell can now no longer reform itself, so it's lost too much of the membrane, so the biconcave disc shape is no longer possible. So we get the spherocyte. This means that they're not really deformable, so they can't escape through the capillary network, which means a lot of them will become trapped in the spleen. Okay, so there we've got the extravascular breakdown. Okay, so just to recap, so this is red cell sequestration. So we've got extravascular destruction due to IgG antibodies opsonizing the red cell, and it can occur with or without complement. If complement has been activated, it has been shown that they will be removed. If they're IgG and C3b, they're removed much more efficiently by macrophages, so they're much more attracted to those as well. So, as I said, with IgG and non-ABO antibodies, the cascade is unlikely to reach membrane attack, so we will get most of the destruction occurring extravascularly. Right, so the other place red cell sequestration, so I need to learn how to say that myself, is in the liver, and that's due to the huge numbers of resident macrophages that are there in the liver. So we don't get the hemoconcentration like we do, but they've got so many macrophages. So you might remember from your biomedical science degrees that they are Kupffer cells, are known as the Kupffer cells. So it does occur in the liver as well. All right, so I want to thank Anas for tweeting this, or whatever we call retweeting now, I don't know. But just look at the way these macrophages are moving through the red cells and having a good old taste of everything that they pass through. This person, if you are on X, then they're worth a follow because they've got some amazing pictures there. So I can't thank Anas enough for finding this, because just the way they move, it's beautiful. It really is that they're going through your circulation doing that. So I've got a question there. How do the antibodies bound to the donor cells avoid being removed before entering the spleen, whereas those attachments are removed? Just trying to think what your question is there, James. So they're not avoiding being removed, it's just that the monocytes that are in the circulation have got their FC receptors completely full, so they're not going to detect, they're not going to pick up on those bound red cells particularly. But when you get to the spleen, there's macrophages with free FC receptors, so they will then leap all over those. So let me know if I've not answered that properly, and maybe we'll come back to that at the end, if that's okay, James. Okay. Okay, so the extravascular trigger, the amount of antibody present is typically far less than in the case of ABO antibodies. Okay, so we've got a reduced capacity to continually activate the complement cascade if it was going to be activated as well. So complement is usually halted at the C3 stage if it is involved at all. Okay, so what about the signs and symptoms? So it's really that the red cells are removed earlier than expected. So we get a drop in hemoglobin and a rise in bilirubin. And this is after 24 hours after the transfusion. So the transfusion that we gave has done the opposite of what we wanted it to do. So we need to find out why. Okay. What causes the complement to activate or to stop in the amplification step? So that's a number of reasons. So not got time to go into them all because really this is an overview of it, but really it's because the amount of antibody and antigen you've got that you've triggered this reaction for will dictate whether the complement will go all the way to MAC attacks. So if you're talking ABO incompatible, then you've got tons of ABO antibody in the person and you've given them a heck of a lot of positive antigen to work with, so you will get complement pretty much to the end phase in that. Whereas if you're giving something with IgG, the person may not have a very high titer, very high concentration of that antibody in there. So hopefully that's answered that question a little bit. We also have limiters in the complement cascade that will sort of prevent us going into breakdown. So that might be another reason why it stops at amplification and other bits along the way. Okay, so hopefully that answered that one, but let me know at the end if I've not. Okay, so when could this happen to my patient? So we've got intravascular, avoidable event most of the time, and it's because we're giving incompatible ABO groups when you read shot reports. So here's my question for you. What does that stand for? It's a lot of typing actually, so if you just want to type the last 3 letters, I'll be happy with that. Yeah, wrong component transfused. Excellent, excellent, excellent. So it's incorrect blood component transfused, wrong component transfused. So the other type of IBCT is specific requirements not met. Okay, excellent knowledge there. Fabulous. So other specificities that can do this, but they're incredibly rare, are when we've got really odd antibodies. So anti-VEL, anti-H, so not to be confused with anti-HI, so this is anti-H, and anti-PP1PK, used to be known as anti-TJA if you've got older textbooks. So yeah, that's great. Okay, so extravascular is much more unpredictable. So if we're so good at antibody screening and identification, why do we still see delayed hemolytic transfusion reactions? Anyone got any ideas on that? Any thoughts? Just what you've seen, what you've experienced? Oh, excellent answers. Yes, low titer antibody below the detection level. KID antibodies, yeah. Dosage effect. Or maybe a masked antibody. So that would mean maybe we've done something wrong if we've got a masked antibody, we've not done our exclusions. Yeah. Undetected. Should we have detected them? Yeah. Got some interesting answers there. Okay. So this is a list that I came up with. Yeah. Oh yeah. Antibody to low frequency. So things that we don't pick up in our screens. That's a very good one. Yeah. So typically it's weak antibodies below detection level. If we're doing everything right, then that's probably the most likely cause. Yeah. Other things are errors, always errors. So we've missed something. We've had an error in the test. We've had an error in the interpretation. The other one is historical antibodies. If we haven't got the records, or we forgot to check the records, or we haven't got up-to-date records. Yeah. So someone's put duplicate record with historical antibody not identified. Yeah. So we do see those things, don't we, in our situations. I think we're getting better at this, which is always a positive thing, isn't it? So I think there was a question that I've missed. For antibody with variable complement activation, is it right to assume that it depends on the amount of antibody? I wouldn't just assume that. Most of the time we don't know how much antibody the patient will have anyway. What we do assume is that for ABO antibodies, you've got tons of it. For anything else, we don't really know. We don't quantify it. We don't do titers except for pregnancies. So I wouldn't rely on that, but I would say it was a factor. So hopefully that answers that question for you. Okay, excellent answers there. All right, so now I'm going to finish off with the consequences, and then hopefully if you've got time, we can have a chat about anything else. So I'm going to compare events. Both of these can result in many adverse effects in the patient. So intravascular is much more immediate, life-threatening, and we've got concurrent and consecutive things going on, haven't we? So we've got different biological substances due to the initial antibody-antigen reaction can quickly spiral out of control. And then with extravascular, We've got opsonization leading to erythrophagocytosis, and we may also get some ionophytotoxin release, which is C3a. So that can still cause lots of damage to the patient. Okay, we've got a question on EDTA. Would using EDTA tubes reduce the sensitivity of test by chelating? Okay, so there is such a thing as, you may have heard of complement-dependent antibodies. It's typically KID antibodies that do this. So there used to be a thought that if you thought you had an antibody that you couldn't find and it was a KID antibody and you thought it was there but you're not sure, you could ask for a serum sample, and that might show up when you did your antibody screen, your antibody identification. Now, I believe that there's quite a lot of people that say that actually, do you know what, that's not as true as we thought it was. So it's possible, I'll give you that. And it's interesting, but I believe the new guidelines are not going to have that in as a recommendation anymore. But I can't swear on that. That would be interesting to find out when they come out. So yeah, that's a great question, is if we use serum samples, would we pick up all of these antibodies? But we use EDTA because it's just convenient for our machines, isn't it? Yeah. Okay. So yeah, where were we here? So extravascular, much more controlled than the intravascular, but it's still happening more quickly than we want it to. So it still can cause problems for the patient, and you've still got excess red cell breakdown products in the body that need to be dealt with, and you've already got a sick patient who's probably dealing with other things. So it's not a good thing to put somebody through this when they're trying to recover from whatever it is they were transfused for. Okay, so there's things to think about outside of just giving the transfusion, aren't there? All right, so let's have a think about the signs and symptoms that we would see in our patient with an acute hemolytic transfusion reaction. So the sheer volume of ABO antibody to ABO antigen will reach the complement endpoint. So we've got antigen antibody complexes activating things like factor 12, and that can result in bradykinin release. Bradykinin increases capillary permeability, which leads to dilation of arterioles. So that can cause the hypertension as well as other things. Hypertension gives you vasoconstriction in the kidney. And we also can get pain sensations. So pain sensations come from bradykinin, plus also your ionophytotoxins. So you've got your C5a, C3a, causing inflammation, tissue damage, and also exacerbating the shock. So lots of horrible things going on already. Got red cell lysis, activated phagocytes initiating cytokine release. That also exacerbates the hypotension and the shock. We've got lysed red cells activating coagulation and thromboplastic substances. So for that one, we're going to get disseminated intravascular coagulation. Intravascular coagulation, and also uncontrolled bleeding at the same time. So we're just going haywire when this happens. We're getting excess free hemoglobin, and this is causing cell damage, tissue injury, damaging to the kidneys. So we've got things like dark urine, sign of excess hemoglobin. And also free hemoglobin is a potent hemolytic agent, and that's going to result in more hemolysis. So we're just really on a downward spiral with this. So what do we do in the first 15 minutes of transfusion? Type it in. What are we looking for? Yeah, observing the patient. So we really, really want to monitor that patient in the first 15 minutes. So check the observations. So often the first sign or the first indication that something is going wrong is the patient is telling us something is not right. And hopefully all of you have heard or have heard of the impending feeling of doom that a patient will report that they know something bad is about to happen. So it's quite scary to think that somebody will be going through that. So they will be experiencing things like chills, fever, and nausea. So we have to ask the patient, because some of these things we won't see. They can only tell us that this is how they're feeling, or this is what they've got going on. Okay, so good answers there. Okay, so for a delayed hemolytic transfusion reaction, initially the transfusion seems to go fine, okay, but looking at 4 hours at least after, we're going to get signs and symptoms beginning to appear. Okay, so we're going to get things like anemia and jaundice from excess unconjugated and conjugated bilirubin. So that's primary signs that we tend to see. And this is due to excess red cell destruction in the spleen and the liver. So HB goes down, bilirubin goes up. And just to make the point that with the yellowing of the skin and the eyes and everything, it's not always easy to see that in people of colour. So it shouldn't really be used as something to say, oh, no, it's not happening, I can't see it. But it is something that we should be aware of, to look for that in everybody where we can. And then we've got other, excuse me, other common signs include things like fever from cytokine production, and then we're going to get fatigue from not having enough oxygenation of tissues and organs. And then as well as that, we can get more serious complications if we've had complement activated. Even up to amplification stage, you can still get inflammation and tissue damage from those anaphylatoxins being released. So you can get a little bit of what we've seen in the acute. We can see that some of that in the patient as well. All right. Okay, so we're going to summarise now, and then hopefully if you've got any questions, we can get onto those. So we know that it's antibody binding to its corresponding antigen. It can cause accelerated red cell destruction. Okay, it's simple as that. We try to avoid that wherever we can. If you've got intravascular hemolysis, then you've had complement, and it's gone all the way to membrane attack. Okay. Where we've got extravascular destruction, it's mainly opsonization by IgG, but complement may be involved as well to the C3 stage. So we've got earlier recycling, and this can overwhelm the body. So still got opsonization going on then. Fortunately, the C3b, as I said, has got a short half-life and degenerates quickly into inert C3d. So we know that one. The antibody characteristics, so there's a whole other talk we could do on antibody characteristics. We just don't have time to go into that. But the main things are they're active by IAT at 37, and we must never forget that IgM ABO antibodies are also active at 37, and they will go to town on the complement cascade. Okay, and the clinical effects, well, they're incredibly wide-ranging. Some people can be given the wrong ABO group and they won't react at all, but we go with they're going to have the worst reaction so that we don't get, you know, terrible things going on. Okay, so that's the wide range, benign to fatal. We err on the side of caution all of the time. We assume the worst thing would happen if we ignore it. Okay, and we monitor the patient, don't we? Every patient, no matter how simple we think that transfusion is going to be, it's every patient. All right, so I've got a question. What does the D stand for in C3D? It's just D. It's one of those things where they just named the breakdown products of as the cascade goes on. There's also a G in there. I don't know why they missed out F or E. So it's actually C3DG that is actually on the membrane, but the reagent we use picks up the D part of it. So it doesn't stand for anything, I'm afraid. Is that okay? Hopefully. Okay, so I've got some references and readings. So if you want to take a screenshot of that, if you're interested in any of the things that I've said today, these are really good papers and books that you could get your hands on. I'm pretty sure most of them are free. So this talk will be on YouTube, but if you want to take a shot of that now, feel free. If you've any of you have got this book, sorry, I don't think that'll no, it won't focus, sorry. So the book at the bottom, Immune Hemolytic Anemias by Petz and Garrity, is excellent. It also covers autoimmune in there as well. So if you're interested in that, it's a really good book. It is old, but it's got some really good stuff in there. Okay, so that is me. I want to thank you all very, very much for listening today. It's been a pleasure. I hope you've enjoyed it. I know I've covered an awful lot in there for you. Hopefully your mind's not blown. I hope you like the complement cascade now, because when you just link it to transfusion, actually, do you know what? It's not that bad. Okay, that's great. So I'll hand you back. And if you've got any questions, please let me know. And as I said, get in touch. Love to talk to you.
That was amazing. Thank you so much.
Thanks, Sabrina. There's so many thank yous and heaps of applause coming through. That's amazing. So we've
Thank you.
We've probably got a couple of minutes now in case we've got anyone who's with us that has a question. I can see we've got a hand up.
Yeah.
Let's have a look. Okay, I'm just going to allow the mic for, I believe it's Maureen. I think it may have been an applause turned into a hand up.
Okay, that's fine.
Can I ask a question, please? I was going to ask a question about the pocket transfusion lab. People might want to know about it.
Sure, if you don't mind. Yeah. What would you like to know?
How do people sign up? What do they get out of it? Anything really?
Okay, so it's I've created a little CPD website, so there is some free stuff on there and there's some paid stuff on there. So if you want to go and check it out, it's pockettransfusionlab.co.uk. I'm trying to run it as cheaply as possible, so I'm doing it for the minimum that I possibly can. What I'm trying to do is identify gaps in people's CPD. So it's all very well doing a course here, there, and everywhere, but if you just want a little bit of CPD, then I'm trying to fill those gaps in there. So not everybody's got time to go off and do certificates and courses and master's programs. So I was trying to just kind of help out a little bit there. So yeah.
Great.
Brilliant.
Thanks so much for being here. As we don't currently have any questions in the chat, but I'm sure you'll get an email or three. So just want to take this opportunity to say thank you so much, Rabina, for that presentation today. What a great start for 2024. Our first meeting of 2024. It's been great for us to get our brains engaged again this year. Huge thanks to everyone that's come along today and asked questions throughout. And thanks, Rabina, to answering them. This month, in fact, has been a record breaker in terms of attendance. So thank you again. We'd love to take this opportunity to ask for some feedback from today's session. So I'm just going to move on over so that we can see we've got a QR code where you'll be able to access our course evaluation, as well as the usual QR code for our YouTube channel. Almost all of our previous talks are available on YouTube. That's especially for those who are new to us today, to the blood transfusion education and discussion group. We meet on the last Wednesday of every month, and so look forward to seeing you again on Wednesday the 28th of Feb at 2 p.m. UK time. We'll be hearing from Malcolm Robinson about the Harvey scan, but from a lab perspective. So just wanted to say thank you again to those who have come along today. And thanks, Rabina. We look forward to seeing everyone again next month.
Great. Have a nice day. Thanks, everyone.